All right, now we continue with our discussions. So another case, wild scenario. They bring you, okay, 71-year-old man. He is on all the medications like Entresto, statin, Lasix, beta blocker for heart failure, right? For EF of 30%. Okay, and then they tell you what's the best next step for this patient. And they give you a bunch of medications, and the answer would be, in this case scenario, they wanna test you how well do you know management of heart failure, because it's pretty common and you need to know that. So you want to give spironolactone, okay? And the management, and they will bring the discussion for management of heart failure, reduced ejection fraction. Initial therapy is optimized therapy, like you could do ACE inhibitor, slow disease progression, improve mortality, and then you give metoprolol, like succinate or carvedilol or bisoprolol. This reduces hospitalization, also improves mortality. Diuretics improves hospitalizations as well and reduces symptoms. This is step 1. Step 2, if somebody still after all of these ejection fraction less than 35, you add spironolactone, aldosterone antagonist. Reduces hospitalization, improve mortality as well. Other options, step 3, if they're still like low and still not optimized, you can add SGLT2 inhibitor. That's a new guy on the block. Reduces symptoms, improve mortality. This is a new study showed that it's a really good drug. Another supplementary drugs, you can do ascorbic dinitrate, hydralazine, and when somebody who does not tolerate ACE inhibitor, like, or have renal issues or persistent symptoms despite other therapy, this one improves symptoms and may improve mortality as well, reduce hospitalization as well. Okay. You can also add digoxin. Digoxin reduces hospitalization but does not affect mortality. So these are kind of the options for heart failure, reduced ejection fraction. So that's why they ask that question, because they want to bring up this discussion. Okay. Now they bring you another question. Okay. Like 55-year-old had endocarditis. He was given antibiotics, Rocephin, or whatever, like cured, everything is fine. Before we discharge him, what to do before discharge? On this patient, you want to educate on antibiotic prophylaxis, and now they want to talk about like what would be which one do you do endocarditis prophylaxis? Like if somebody have prosthetic heart valve, if somebody have previous valve surgery using prosthetic material, if somebody had previous endocarditis, like this patient will have endocarditis, like he will need prophylaxis for life. If somebody have unrepaired cyanotic congenital heart disease, if somebody have repaired congenital heart disease with residual shunt or defect, valvular disease in a transplanted patients, if there's valve disorder in a transplant. Okay. And you need these patients, you need prophylaxis only if they do dental work with gingival manipulation or respiratory tract procedure with incision or biopsy. And what's the first line? You do amoxicillin. If they are allergic, you do cephalexin, azithromycin, and doxycycline. Okay. Well, this is like a summary of the endocarditis prophylaxis. Okay. Now they can bring another case. Like with someone $75 man with lightheadedness and dizziness, you know. A1C is 7.9. Okay. And then they bring a bunch of other things, some orthostatic hypotension, 2 hours after eating meal, and they want to tell you what to do next, like for this patient. Like have orthostatic hypotension, this is a pretty high level. Orthostatic hypotension after food, what's best next step? This patient you want to do tighter, smaller, more frequent meal. Because this patient, the blood will pull to their stomach and then they fall. So we want to do small, more frequent meals, low carbohydrate diet, increase salt and water intake, avoid alcohol, custom fit compression stocking, okay? Avoid activities with sudden standing immediately, especially like at this age, okay? Alright, so now you see another patient, you see another case who's, let's say, 67 with ST elevation, 67 male, of course male, ST elevation, had ST elevation in inferior lead with chest pain, absolutely, and then echo EF shows 50%, right? And then they tell you, but what's the best next step? In this patient, you want to do cardiac rehab after heart attack. It would be very helpful, like, to do cardiac rehab, okay? So this is to keep in mind, okay? Because improve functional status, reduce hospitalization, reduce recurrent MI, all-cause mortality. It's very important after recent MI. Alright. And then they bring another case, somebody who had smoking history, like somebody who's 67, smoked for like 1 week or 1 day in the past. And they tell you what's the best next step. You want to do abdominal ultrasound. The guideline you want to do abdominal aneurysm ultrasound. So you want to check for like AAA ultrasound for these patients. The guideline, if they're smoked ever 1 time. So if any man age 65 to 75, any smoking history, you want to do 1-time duplex ultrasonography, and that's it. You're good. You're done with it. Okay. And they want to discuss also the ideal screening program in this case, like if somebody has long asymptomatic phase, high prevalence in screened population, and you want it to be low cost, the screening program, you know, and avoid overdiagnosis and lead time bias, improve outcome. These are kind of the characteristics. This one is simple, very simple, easy test to do, and could prevent a huge comorbidity, you know, so it doesn't hurt just to screen them 1 time, once in their lifetime. Okay. Now, another case that you would encounter as well, they can ask you about 43-year-old woman came in with a hollow systolic murmur, right? And EF 65% with the mitral valve prolapse and severe mitral regurg, and they bring you pulmonary artery systolic pressure, and they will tell you what to do next steps. Kind of like the previous question to what to do. What do you want to do? Do you want to do surgery or not at this point, huh? So because it's 65% and asymptomatic, you know, in this patient, you just want to repeat echo in 6 months. It's better, okay? 6 months. Okay, now the question is, because they want to discuss that, discuss other options. When do you do surgery though? Okay, you do mitral valve surgery, repair more than replacement when possible, only if the ejection fraction between 30 to 60%, or more than 60% and have symptoms. Okay, that's the only one. The one, if it's more than 60% asymptomatic, as in this patient, you just repeat echo every 6 to 12 months. Okay. You can do surgery if there is high likelihood of durable repair as well. But if somebody has EF and mitral regurg has EF less than 30%, it's better to just medically optimize them. Surgery case by case. This way, specialists would take care of that. But usually, just medical management, because there's very high risk for mortality, you know. All right. Let's go to the next one. So this one is another high yield case. So the way they ask it, they are bring 62-year-old woman with sudden shortness of breath, hypertension, like 200/100, chest X-ray show pulmonary edema, right? And they will ask you, what's the diagnosis? So what disease that causes recurrent pulmonary artery hypertension, recurrent pulmonary edema, and flash pulmonary edema? One that is most common one is like when there is bilateral renal artery stenosis. So there is hypertension related symptoms like resistant hypertension, uncontrolled despite free drug regimen, malignant hypertension with end organ damage, onset of severe hypertension more than 180/100, 120. Okay, this indicates renal vascular disease. Severe hypertension with diffuse atherosclerosis. If there is recurrent flash pulmonary edema with severe hypertension, this could make you think of renal stenosis. So it doesn't hurt to check for that if there is a suspicion like of resistant hypertension, malignant hypertension. And other supportive evidence, asymmetric renal size, more than 1.5 centimeter, abdominal browi, and lab, you will see unexpected rise in serum creatinine more than 30% after starting ACE inhibitor or ARBs. Okay. On imaging, you can see unexplained atrophic kidney as well. Okay. So these things are very important and very high yield for real life and for the exam, like recurrent severe hypertension, you see that a lot. Okay. So you want to make sure you're not missing renal artery stenosis, because especially if you have atherosclerosis, increased risk for that. Okay, another case you could see, let's say 61-year-old executive man, okay, whatever, comes to the office with light-headedness when getting dressed. What's the best next step? This patient, you want to do carotid sinus massage, because, and I'll tell you why. This is like carotid sinus hypersensitivity. So there are all different types of syncope now they want to discuss in this case. It's good to bring it. Could be vasovagal, like when there's prolonged standing, usually associated with prodromal symptoms like nausea, warmth, and diaphoresis. There's also situational, like with cough micturition. There's orthostatic, more like after standing suddenly or after food. Aortic stenosis, like with exertion. Arrhythmia, there's history of heart disease, MI, cardiomyopathy. Sick sinus syndrome, if there is PR interval prolonged or QRS prolonged. Tarsa de Ponte, if there is hypokalemia, hypomagnesemia, medication causing elevated QT interval. And there is congenital long QT. Usually it's history of sudden death, increased QT interval, syncope with triggers, exercise. Okay, these kind of things. Okay, another question that they can bring, they want to see, okay, what are benefits of milrinone? They bring you a long question and they just want to know this. Okay, the benefit is improved dyspnea, that's it. Like on somebody with heart failure. It's usually an advanced heart failure, improved shortness of breath. Okay, now they also want to know, like for cardiology, something very high yield, like somebody had a drug sirolimus, like somebody had an MI. Okay. Came in with a pre-op, let's say 60-year-old here for pre-op knee evaluation. Okay. And he just did the heart, like 4 months ago had a heart cath and had a drug eluting stent, right? With drug eluting stent, of course, they're gonna be on a bunch of medication, like aspirin and prasugrel most importantly, otherwise to avoid restent thrombosis. But next step, you want to postpone surgery, okay? that bring a good discussion of when do you recommend the duration of therapy. Minimum 6 to 12 months after bare metal stent or drug loading stent. That dual antiplatelet for minimum 4 weeks and select patient after bare metal stent. And then you want to continue dual antiplatelet for total of 30 months if possible, low bleeding risk, and continue aspirin indefinitely. Okay. Pre-op evaluation. If there's elective surgery, defer surgery until minimum duration. Okay, which is 12 months, 6 to 12 months. If it's urgent surgery, then you would just continue P2Y12 and receptor blocker, which is prasugrel in this case, or hold for the shortest duration possible. Okay, so you can, it's a clinical judgment. Aspirin you want to continue unless high risk of severe surgical bleeding. Okay, this is very important. Okay, and the last discussion, let's do this question. UC 64 with pain, your old man, came in with swelling, erythema over defibrillator generator, and had fever as well. This next step. So he's symptomatic, and the defibrillator is having erythema and swelling. Oh, this is scary, right? So what you want to do, this one you suspect infection, right? Suspect infection of the defibrillator. So the best situation that you want to do, removal of the generator and lead, followed by antibiotics. Okay. So that would be the answer here. Alright. So just to summarize the things that we discussed about today, so remove the infected generator, postpone surgery for dual antiplatelet, recent MI, melanon improved dyspnea, cardiac sinus massage for hypersensitivity with dressing, bilateral aortic stenosis can cause artery stenosis, pulmonary hypertension, repeat account 6 months for mitral regurg that's above 65 without symptoms. If you ever smoked, you need the ultrasound of the abdomen, smaller, more frequent meal if you're dizzy after food. Educate antibiotic prophylaxis for somebody who just had endocarditis, spironolactone for heart failure. The EF is less than 30% still after ACE inhibitor and beta block. That concludes our discussion for the third section of cardiology. Thank you for listening.